Good morning, everybody. I'm here to talk about two studies that we've done. In total, it's a retrospective study of the diphtheria outbreak that occurred throughout West Africa, but specifically in Kano State in Nigeria from 2023 to 2024. So, since 2023, there's been a multi-country diphtheria outbreak in many countries in West Africa, including Nigeria, Guinea, Niger, Cameroon, and Gabon. Nigeria has been the worst affected, with approximately 26,000 confirmed cases across 26 states from January 2023 through to March of this year. Kano State has been the epicenter within Nigeria, with over 18,000 confirmed cases and 850 deaths. And within Kano State, the highest number of cases have occurred in Kano City, and facility data suggested an attack rate peak of over 500 per 100,000 population, which equates to about 0.5%, specifically in Ungogo, Fagi, Nasarawa, and Dawa-Kintofa local government areas. And those 4 LGAs are where we conducted our studies. So MSF Western Central Africa played a prominent role supporting all pillars of the response, primarily in case management, and they established diphtheria treatment centers where they administered diphtheria antitoxin, gave antibiotics, performed airway management and supportive care to patients. But they were also involved in infection prevention and control, vaccination, surveillance and epi, and risk communication and community engagement. During the peak, a number of cases went from about 100 per week through to close to 800 per week, and there was insufficient diphtheria treatment center capacity to cope with this. And so MSF WACA developed and implemented a novel home-based care strategy to reduce pressure on the DTCs. And what this looked like was, at triage, any mild patients who presented during this period where you see the green arrow were provided with oral antibiotics and discharged. They were followed up at days 3 and 7, and there was a weekly outpatient department visit. If at week 3 there was no deterioration, the patients were vaccinated and discharged. And between January of 2023 and March 2024, MSF WACA treated approximately 15,000 patients, 8,000 in diphtheria treatment centers, which you see in light gray at the bottom, and 6,700 in home-based care, which is the darker bars. So our study objectives were, firstly, to describe the impact of the outbreak in terms of the attack rate and case fatality ratio, to explore the impact of care-seeking behavior on mortality, and to evaluate this novel home-based care strategy, which was again used for mild cases. And we looked at mortality, specifically case fatality ratio. We assessed the acceptability and perceived quality of care that was given, long-term sequelae among survivors, and within household secondary attack rates, which is defined as any secondary case within 30 days of the onset of disease among the primary cases. So we had 2 studies that ran in parallel. For the impact of the outbreak, we did a population-based retrospective mortality and morbidity household survey. We used spatial sampling with 65 clusters of approximately 15 households each, and the recall period was from January the 1st, 23 through to the survey date, which ran somewhere in September, October 2024, approximately 631 days. For the home-based care strategy, we performed a matched retrospective cohort study of mild diphtheria cases. We matched on age group within 5-year bands, sex, vaccination status, and geographic location. And for sampling, we used, as a sampling frame, MSF WACA's patient registries. So for the household survey, where we were looking at the impact of the outbreak, we recruited close to 8,000 study subjects. 88 community cases of diphtheria were detected. These were not confirmed, but these were using a community case definition. This gave us a crude attack rate of just over 1%, which is approximately 2 times the highest pre-study estimates based on passive facility data. It was highest in children aged 6 to 10 years, at about double that. And for mortality, we detected 110 deaths, 59 of whom were among under 5s. And diphtheria accounted for 7.3% of all deaths detected, and this was actually 10% among the under 5s, so quite a high proportion. Case fatality was 9% overall, and double that among the under 5s. And for risk factors, we found that age was a major risk factor, with a mortality rate ratio among the under 5s of 8.6 compared to the over 5s. Vaccination status, with a mortality rate ratio of 2.3 among the unvaccinated compared to the vaccinated. And care-seeking behavior was a very important risk factor. And we found that mortality was 40% lower among those who sought any care at all, and was 17 times higher among those with delayed care seeking, among those who did seek care. And this was defined as seeking care after 3 days or more from onset of disease. Looking at the home-based care strategy, where we did the cohort study, we recruited 678 patients, 367 in home-based care and 311 from diphtheria treatment centers. Remember, these were just mild patients, so the case fatality ratio was 3.6 overall, 1.9% by home-based care, and 5.5% according to diphtheria treatment center. So we found no evidence of higher mortality by home-based care, but of course we found higher mortality by, within the diphtheria treatment centers, which we dug into the data a bit further. We found this was likely due to confounding by severity. So even though we were only meant to be looking at mild patients, we did find that there was some evidence that this severity variable was not very well recorded in the database, and we found some patients with complications recorded, and that should have excluded them. When we removed these patients from the analysis, we found there was no difference between the two arms. There was very high acceptability. Out of an average score out of 5, it was 4.7 by home-based care, 4.8 diphtheria treatment center, so very high in both groups. For long-term sequelae, 2.1% overall. It was mostly minor or short-term, no difference by treatment group, but it was strongly associated with complications, with an odds ratio of 30 among those who had complications. And again, secondary attack rate was 4.2% overall, so 4.2% of close household contacts of primary cases became secondary cases themselves. There was weak evidence of a higher secondary attack rate in diphtheria treatment centers, at 1.5, the secondary attack rate ratio, but it was much higher, again, among patients with complications, so a secondary attack rate ratio of 6.1. So this was a high-impact epidemic with a high attack rate affecting up to 2% of the population in the worst affected areas, and this was between 2 and 4 times higher than the facility data implied. And this suggests that there was a large number of undetected community cases that never presented at facilities. Diphtheria accounted for a substantial proportion of all-cause mortality, and there was high case fatality ratio, particularly among the under 5s. We also found that early care seeking was strongly protective against mortality. Care seeking at all, but specifically early care seeking. And for the home-based care strategy, we found no evidence of worse outcomes in home-based care compared to DTCs in terms of mortality, sequelae, or secondary attack rate, and both were equally well accepted. So again, this was a high-impact epidemic with high attack rate and mortality. A relatively small proportion of cases were passively detected through facilities, and this suggests a need to reinforce community surveillance, including active case finding and contact tracing, and early care pathways to ensure earlier and greater treatment coverage, and therefore better outcomes for the patients. And in conclusion, we found that home-based care can be a safe, effective, and acceptable strategy for mild cases in outbreak settings where there's limited bed capacity, noting that most diphtheria cases are non-severe and would be appropriate for home management. And home-based care has the potential to increase access to healthcare and shorten treatment delays. And I'd just like to end by thanking and acknowledging the work of colleagues in the field, in particular staff at MSF West and Central Africa, Suleiman Hudu and Khadija Utman in Kano, and Frank Ale in Abidjan, but also our colleagues at the Kano State Ministry of Health, Nigeria CDC, and Etienne at Epicentre. Thank you very much.